Hi, and welcome to an educational webinar with Telecare. Today we have Dr. Raj Anand, pain specialist and rheumatologist, giving a talk about pain management in people living with dementia. Enjoy the session.
Specialist and a rheumatologist, currently work based in Sydney, work at St. Vincent's Public Hospital, Prince of Wales Private, a Royal Rehab at Ryde, where kind of currently leading brain injury and spinal cord injury and pain project. This is a whole New South Wales wide project, and working with Telecare online for nearly over a year now, and do a bit of consulting for a few other companies. I do know, I don't know how many of you, earlier in the year, I'd done another talk, but that was more specific and based on dementia. And more recently, I'd done a talk just on pain management in general practice. I just thought I'll share some of what I had done in the previous talk. But again, as described previously, we'll keep it very informal and basically kind of see how much of it can be practical in day-to-day practice, and just feel free to jump in at any point. Yeah, and I think largely trying to share some of my experiences, and again, trying to keep it as close as possible to current evidences, though a lot of current evidence is either extrapolated, particularly in the field of pain, from smaller studies, or particularly in the aged elderly population of people with dementia. We extrapolated from other studies and kind of see how people respond. And I think a common question which I think we all face is, Doctor, I've been on the pain pill and why am I still in pain? Or how do we currently, more recently, at least in the last 6 months or more after the new opioid regulations, I think there has been definitely a whole lot of talk about opioid use, and definitely a lot more referrals in different pain clinics about the role of opioids. It's kind of presented three different patient groups among who I see. And the one group who have been on high doses of opioids for a long period of time, for many, many years. They have been stable, or no one has reviewed the dose for a long time. They've just been continuing on the same doses. And when we've kind of spoken to them, some of them have been willing to reduce it. Have a few patients who have completely gone off opioids and have made no difference to their pain levels, or some are even functioning better. And there's also another group of people where they've tried to reduce, and it has upset them, both from a physical functioning and psychological functioning, and a lot of anxiety around these medications. And it's always a challenge, and sometimes it's about kind of developing a relationship with them has been something which has been very important in kind of sitting down and kind of working out into the different reasons into why we are using different medications, or where the role of each of them are. I think just as an example, I mean, this is a story which has stuck into my mind about a person who I was referred when I used to work previously at the Dementia Center, where I used to kind of support a lot of center, the DBMAS and the DSA Center, with pain management in their clients. And this was a case from that time. It was a rest home resident. Pain, he screamed, for how long, I know not. Pain, he screamed, why, I know not. Pain, he screamed even more than before. Pain, he screamed. Then he was shifted to the last room in the home. Sorry, pain, he screamed when he was usually alone. Pain, he screamed. Then more medications started to quieten his voice. Pain, he screamed even more than before. Pain, he screamed, and then shifted to the last room in the home, and no one heard him scream anymore. And kind of setting a scene, and it's not something which happens often, but many times Quite often in the clinic, when people say they have pain, it becomes hard to know many times when they're not able to communicate where the pain is coming or what do they mean by pain. Or in my clinic, I do see uh, an elderly lady who's in her 80s, has moderate dementia. She's reasonably high functioning, and every time she comes along with her husband, and every time when I ask her, "Do you have any pain?" and she would say, "No, I have no pain, absolutely no pain." But then again, her husband constantly keeps saying no, she has a lot of pain, and they kind of keep a record of how much endone and or Norspan they use, and they kind of constantly. She says every 2 or 4 hours she has been using a bit of endone, but again, it's very hard to know is she truly in pain or what's happening over there. Are they using endone to keep her quiet? It's an extremely challenging consultation, because why are we using opioids? Because every time I see her in the clinic, she says, "No, I have no pain," or she's even seen a geriatrician, and when he is seen too, the history is very discordant. So again, that's a huge challenge. And when the carer feels that the person is in pain and might benefit from opioid, and again, when we see them in a brief consultation, it's very tricky there, and there is minimal pain or minimal use of opioids. And again, we've tried to kind of wean down the total use of opioids, again, to kind of balance it to function. And again, particularly in the elderly group, the biggest risk is what's the risk of each of these medications. Again, which pill to give? There's no specific or magical advice there, particularly coming back to pain. And there's a common image which has been shown in a lot of pain talks about Rene Descartes and the path of burning pain, about how the message of pain was taken up into the brain through a hollow tube and rings a bell in the brain. And this was even before the discovery of nerves, and this kind of changed the way modern sciences looked towards pain. Before that, they attributed pain to various other causes. But since this, the kind of we went into kind of looking into what are the physical causes of what's happening within the body. And this is very important, particularly in acute pain, or when there is a change in the way the pain presentation happens, always to kind of see, is there any nociceptive element or focus? Is there any acute change, whether it's inflammatory or infectious or malignant? Is there something going on? And this kind of led to the search for how can we fix the pain. And we do know a lot of people have surgeries of different nature, but it has not necessarily fixed all the issues of pain. And that kind of leads into the chronic pain scenario, into whether it's the lower back pain or pain from headaches and abdominal pains and even osteoarthritic pain, into what causes some of these features. We do know some of the things, particularly in the pain experience, some of the modifiable factors and factors which can lead to a higher intensity are features such as catastrophization, where people feel helpless, or people magnify or have a negative narrative or outlook to things. They have shown to have a higher pain intensity, and the same as self-efficacy. If they feel they can't manage it, that definitely makes it harder. Or people with the lower self-efficacy do have higher pain interference. And sometimes even the terminologies we use, like degenerative arthritis or L5S1 discs, or so people look into the reports of imaging and kind of try to hold on to diagnoses or have their own conceptions on what it means, whether it's bone on bone. And or again, these days when people start looking into what are possible causes, sometimes that can also kind of amplify their somatic symptoms, or kind of looking into more hypervigilance can be arousing. Again, emotions play a big role. Pain and emotions are very close friends, particularly fear and anger are, and sometimes and sadness too, which can be presented as depression and anxiety, which kind of run hand in hand. Particularly in chronic pain, it's not that pain causes uh, depression, but I mean, in the sense, both run side to side. If they had previous depression, that can make it hard. And there are a lot of studies to kind of show that people who've had depression, even before they've had pain in the future, they have a higher incidence of developing chronic pain, and vice versa too. If people have had been in pain for a long time, that can affect their mood. Pain also sets up a lot about fear and anxiety. So anxiety is also something which we commonly notice, and that could be even circumstantial, or it could be pre-existing anxiety into other aspects of life. And again, the way we manage pain can also vary based on our own cultural influences, and even in different homes, we all deal with pain very differently. Some seeking medical help and some seeking no help. And how do we get the right balance? And again, lots of fears about what to discuss and what not to. And we also do know that previous life experiences definitely help shape their current experiences, and what needs to be addressed or what has been resolved is also something again important to look at. And coming to the elderly population, looking into frailty, looking into their physiological changes, looking into their physical changes too, into what is their cardiac function, their respiratory function, the different functioning of their organs, whether it's the renal and the liver function, the level of their BMI and fat distribution, and other medications. Many times there is polypharmacy and multiple comorbidities, which play a big role in the presentation. It's very unlikely that a person has a single problem or is on a single medication. It's about how do we tailor the pain plans according to each individual. I might just take a small break for a minute if anyone has any questions or anything, and we can kind of direct the conversation in that direction.
Hi, Raj. I think we had a question from one of our group, but just about recommendation for steroid injections in osteoarthritis, when to kind of consider that or to use that instead of oral analgesics.
Definitely, there has been a lot of studies done in the scheme of things, and again, steroids are beneficial when we put it in the joint. But again, what is the harm caused by steroid injection? And that's where it's the bit of the bigger balance and the bigger questions. Again, a part of it remains a little unknown in the sense, what's the from a cartilage point of view, how toxic is the local anesthetic and the steroid. And there are kind of studies which show that people who have more steroid injection do end up having a higher degree of joint related replacement. But again, it's a bit of a chicken and the egg story in the sense, do we inject people who already have a high degree of pain interference and thus ending up having more joint related issues? But again, I do use them. Different people have varied response. Again, a part of it is about seeing what are we trying to gain from this person's view. In the sense, will it improve their function, like from a shoulder joint injection? Do we inject the shoulder, or from a knee joint? Again, access, can we do it in the patient's room if they're in aged care, or do we get it done under ultrasound? And again, as an interventional pain specialist, sometimes we do it under theater, under sedation, where we can do many joints at the same time. In the field of interventional pain medicine, again, there's a bit of a move. Again, I mean, rather than using individual joints these days, especially in osteoarthritis, one could consider doing radiofrequency ablations, which have kind of increasing. There is more and more evidence there. But again, the role there comes into what should be done first. Do we do radiofrequency, or do we do it in post-surgical context, or in patients where surgery is not an option. In my personal experience, places where coming to radio frequency, I don't know, for people who have not heard about it, it's basically we use a 20 gauge or 18 gauge needle, which are placed under fluoroscopic guidance into around the nerves, supplying the articular surfaces, like for example in the knee, they would place it along the genicular nerves, supplying the knee joint, the superior medial, the inferior medial, and the superior lateral, and sometimes the infrapatellar, and then radio frequency waves are given, and that can be either pulsed, where they increase the temperature to 42 degrees, does not burn the nerve, or you could take the temperature up to 80 degrees, where you coagulate the nerve, and that's what is called a radio frequency burn. I think the most commonly used joint is the facet joint, and I think that's where the biggest evidence lies. When you burn the medial branches supplying the facet joints, each facet joint is supplied by two medial branches, from the nerve above and nerve below. So that's a very commonly used procedure. The nerves do grow back, and the aim is that it would provide a more lasting response. But again, we do not visualize the nerve, and there can be anatomical variations. And again, needle placements can vary, and so the results can also thus vary. And the peripheral joints, where they do it more often these days, knees are very common, hips and shoulders, more and more people are using it to manage chronic osteoarthritis, which are not being which the surgeons are not being able to operate, or people with chronic pain where the role of surgery is low. So I have used them. The other common joint where I have found very helpful has been the small joints of the hand, particularly the CMC joint, where we use a smaller probe, and sometimes in people with seronegative arthritis, where the inflammation is partly under control but not fully, and they have a lot of pain in their joints. But again, if there are a couple of joints, it's easy to do a pulsed RF. Again, the issues there is availability and access. I mean, if you are closer in the city or more closer to a pain service, that's one challenge. The other thing is currently a lot of these procedures are being done more in private hospitals. Very limited public hospitals do them. There are hospitals like in Sydney, they do, but again, the waiting lists are long, and they do a much smaller number. Those would be challenges. And again, with steroid injection, going back a couple of things. Again, how long does the effect last? Sometimes it does help in a diagnostic way to kind of see whether a single injection can give them a more prolonged quality of life. And what usually happens over time, repeated injections, one, there is an accumulative burden of steroid, or the efficacy of these injections do reduce. And many times, like even in frozen shoulder, for example, where they have injected after 4 months or 6 months, things kind of come back. Whether you inject or don't inject, they kind of come back to the same level of activity. The people with injections, post-injections do drop down a little, and the people who have not had do pick up. So again, there are values, but again, it's about evaluating it from case to case. And again, from the person, what are we trying to achieve there becomes helpful. And again, people say, yes, it is opioid sparing. So again, do we consider it? But again, steroids have their own risks and harm too. The other things, I mean, once in a while, where we do come across when you inject too many infections. So that's always something, a risk we exposed to. And quite often, flare-up of diabetes is another common thing. I notice, very rarely, if you inject it closer to tendons, there's a risk of tendon rupture. So these are some of the harms of steroid injection, in the sense it's not a completely benign procedure.
I think there were a couple of other questions that came through. So
Yeah.
probably one following up was, is radio frequency of the hip joint nerves used in patients who are unsuitable for surgery of the hip?
Yes, they kind of burn the obturator nerve, I mean, the articular branches of the obturator nerve and the femoral nerve. So they do use that both in people who have post-surgical hip pain and in osteoarthritis of the hip, where surgical options are not possible. So those would be two situations where they could consider radiofrequency ablation of the hip.
Thank you. I think there's another one that was asked by Silvana, which actually is quite important for quite a lot of us. It's just in regards of, your case of difficulty of knowing how much pain is being experienced by someone with dementia. How useful are these pain charts that nursing homes utilize or judge management decisions on, and when should they be used?
It's a very important thing. I mean, in the sense, I would definitely say having a scale is important. I don't think I have a slide here on this particular presentation on it, but we can move out to some of the dementia measurement tools and scales. The biggest challenge is when there is no scale used, then it becomes even more vague, where people just we just rely on the observer's comment. If the nursing home resident or the carer says they are in pain, then we just have to go by their word. So I definitely feel having a scale is very helpful, whether it's ABI or more recently people have been using the pain check, which is the app, or pain ad. These are the more commonly used ones. If you look at the ABI pain scale, for example, there's no guide, and why we say 0 or 1 or 2 is very observer dependent and depends on their training. Again, what I have found more helpful, whether it's in ABI or whether it's in pain check, particularly in pain check, a lot of it is yes or no, and pain ad also is a little bit more objective, looking for certain reactions. Rather than the final score, looking into individual aspects of what they're marking on each of these scales is definitely much more helpful. Saying, okay, is it the vocalization, or is it what functional interference is there? Is it during shower, or is it sleep which is affected? Is it mood which is affected? So looking into those individual factors which give the final score, like a pain check of 13 or 14 out of I think it's sort of 42 or 37, sorry. That number by itself is not so meaningful, and I don't think they've done large studies, though they kind of say mild, moderate, severe. I don't think there are too many studies there to kind of say what is mild, moderate, severe. And we know also that pain intensity of the pain treatment is not based on whether it's mild, moderate, or severe. Many times the treatment or whatever we are going to do next is not necessarily based on purely based on the pain score. So I think looking into what aspects of functional interference are there can be very helpful in also selecting what sort of treatment might be helpful. Just as an example, if quite often we see, I mean, in the sense, people have pain during shower times, maybe a time when there's a lot of behavioral interference and people find it very challenging. So is there a role of using a short-acting analgesic before 30 minutes or an hour before the shower, whether that's either simple paracetamol or a very low dose opioid is sometimes which we have used as a trial, or if they say sleep is the major issue in that context, and if they have a bit of neuropathic type pain, would a very low dose of gabapentin, usually I start about 100 milligrams if I'm gabapentin, or 25 of Lyrica, to kind of see what difference it makes. Again, the biggest challenge with all of these medications is the harm, the risk of falls, the risk of confusion. Already somebody who has cognitive effect, and that's a big challenge. But again, that's where functional, how is their function becomes very important marker of assessment rather than just what the pain intensity is. But most dementia scores involve some aspect of function. So looking into the whole, how did they arrive at a particular number becomes more helpful there. And again, talking to the person still becomes helpful. I mean, whether we are able to get a reliable information or not, again, it's very important to kind of see what they feel is very helpful. And again, quite often the other thing is also pacing measures are very helpful in this situation, particularly in people who are in a wheelchair or those who have very limited ability to transfer. Sometimes they're being transferred in the morning from the bed to the chair and left in the chair for the whole day. And kind of towards the end of the day, they kind of have more pain or more discomfort. And times when we've been able to institute a midday break or a nap, those people do a little better, though there are a lot of logistic challenges into both from a nursing staff and a care staff on how we can organize them. But when we've been able to organize for some of them, it's definitely worked very well, particularly in people with lower back pain and have been stuck in one position for the whole day, whether it's sitting in the chair or lying in the bed from evening 5 till the next day morning 8 or 9 when the care staff come. So again, those are things, again, something to work with the staff and educate the staff on how they can kind of just simple postural changes can also provide good relief there.
Raj, I prescribe a bit of pain medicine in my perioperative work. And sometimes I wonder about opioid hyperalgesia and whether just stacking on the opioids, when do you start running into that problem where it's not actually decreasing pain but making things worse? Do you find that there's a sort of a dose of oxycodone or whatever pain medication you're using that above which you're a bit reluctant to go?
I think definitely, I mean, opioid-induced hyperalgesia is a very useful theoretical component, again, much more in shorter-acting opioids, fentanyl, and in kind of remifentanil type of medications more, as that's the thing where they've shown. But definitely saying that in people with higher doses of opioids, over 100 milligrams, though it's not necessarily a dose-related phenomena, but an oral morphine equivalent of over 100 milligrams, that's something what we constantly question is if, and I've definitely seen that in people who are more than 300, 400 or 500 milligrams of opioid. When we reduce the overall opioid, their pain levels are much better. Another common phenomena where we notice is in people with headaches, when they've been on opioids for a long time or any pain analgesic, and when we have completely stopped the opioids, actually the headaches get better. Again, do we just call them medication-induced headache or a bit of opioid-induced hyperalgesia? But the key ways to test over there would be to kind of reduce their overall opioid dose and see how they go. And many times, or even increase, many times we reflecting upon to the patient itself, which I quite often do is, see, we started, I mean, in the sense, a year ago, you were on 10 milligrams of opioid, and today you're on 1,000 milligrams and still having more and more pain. So I think opioid is actually not working here and we need to work down. Quite often see that in fentanyl, and though I think the use of fentanyl over time, I think is gradually reducing. You may have to correct me, but that's something which I've been noticing. I mean, again, because of the oral morphine equivalent, I think what they have definitely noticed is over 60 milligrams of oral morphine, your risk of the adverse effects and mortality significantly goes up. So I think I try to keep it to about 100 milligrams. Again, there are people who have been on a high dose of opioid for a long period of time. Again, with them, it's about constantly having re-explaining, engaging, kind of motivating. It's almost a bit like using strategies to stop smoking or reducing alcohol intake. Kind of gradually kind of getting them on board and then reducing it. It's a bit of both. a little bit of rules around it, but if they engage, definitely the process is much more easier, and I think there's less disengagement. And I have what I have noticed. Again, I might be coming in as a good cop, bad cop kind of a situation, where many times I usually do not make too many changes, at least in the first visit. I mean, I know it's very hard in a GP setting when someone just turns up to your doorstep and says, I need 20 OxyContin, or recently I had a patient who was on 1 box of hydromorphone a day. That's 20 tablets of 8 milligrams hydromorphone a day. And again, if someone like that turns up to your doorstep, it's going to be very challenging into would you give it, or how do we deal with it? But even there, I think a bit of engagement, being able to kind of contain and work with them to kind of see where it goes. Again, in this particular person, a bit of the loophole was he was diagnosed with multiple myeloma. So the initial treatment was started in the context of neuropathic changes secondary to chemotherapy and multiple myeloma related neuropathic pain. But there was a lot of escalation of doses. Multiple myeloma has been stable, but for the last 5 years, now I think opioids have become an issue. So again, I think that's another group of people we see who are on different opioids, sometimes even up to 2-3 grams a day. Many times they are kind of started in the context of palliative care or people. And transplant is another common situation where people are palliative, but once they get the transplant, then they're healed or they're kind of cured, but then they're still stuck with opioids. So that's an interesting group of people.
We just got Dr. Gabir Kaur coming to join us as well. She's another pain specialist with Telecare. Hi, Gabir, how are you?
Hi, Chris. Thank you. Very good.
That's good. I just thought I'd ask her to come along just because the issue of radiofrequency ablation and procedures came up from the group, and I know Gabir is Melbourne based and does do these procedures. So I guess my question is, do you think that radiofrequency ablation or local injections for nursing home residents, is that something that's beneficial? Do you think it's underutilized, or do you think that these patients should generally just be managed with medications? What's your view?
Yeah, so I mean, if you had asked me this question a few years ago, my approach would have been different. But currently, I feel treating nociception is primary. So whether it is, osteoarthritis of the knee, whether it is back pain, so addressing the nociception means that you address the specific pain problem for them, and then overall the medication requirements go down with time. And we know that medications have heaps of side effects, if the risk of fall, progressive dementia, and so on. So yeah, treating nociception. However, the approach sometimes is different than a younger adult, for instance, where for an older individual, it's hard for them to keep coming back in. So I would sometimes organize for facet joint injections versus in a younger, adult, where I would go middle branch blocks and do a radiofrequency ablation of the nerve. But I believe the results are really nice with dealing with specific pain problems. So I currently have 3 to 4 nursing home residents, and the response has been fabulous. So there is a requirement for endonheptagen has gone down, and they're overall happier. And also from, if you look at the mechanistics of, what is causing pain, it's just so essential to know whether we're dealing with nociceptive problem versus neuropathic, so that the treatment is addressed to the type of pain that they're experiencing. So between a facet joint injection for a nociceptive problem to a nerve root injection for a nerve compression, or, whenever the nerve, there's a radicular pain or radiculopathy present, it's worth differentiating. And also, lots of these elderly people do not want to have many more surgeries, but if they did choose to have surgical operations, it's just worth knowing whether a nerve root injection was successful, and that will, of course, alter the course of the decision making, whether they should go through a surgical pathway. Often they choose not to.
Yeah, no, very true. And again, The bigger challenge is, hi Gurveer, just to
Hey,
jump in.
Raj.
I mean, particularly with dementia patients, I've had a few people with very severe dementia. I mean, a couple of them who come in, challenges there are consent, or they come out in the theater room and it's very hard to even know where the pain is, or you discussed a few weeks ago saying, okay, this is what we're going to do. And then they're kind of in front of you at the table, and then you ask them, where's the pain? And they say, okay, no pain. And then it's very challenging. I mean, I think there's lots of logistics. I mean, definitely high functioning or people who are able to verbalize, it's much more easier to kind of, from a procedure point of view, but people with more significant dementia can be challenging. They're saying that we have done for a few people, but there are a lot of barriers in kind of getting them across. The logistics involved have always been something which I found very challenging.
That's right. And so you come across a scenario where, you're ready to inject this person and you go, what's your pain score today? Oh, doc, I have got no pain. What am I going to do on you? So absolutely, yeah. But other times, I think, carers can mark on their back. So, if they say at a certain time my back is sore, I'd get the carers to mark. Because yes, but by the time patients come to you, either they have no pain, they've forgotten about it, or the medications have managed it, and you go, what am I supposed to do with you? Yeah, it's challenging, but very interesting at the same time.
Well, we've got another question from Ellie, maybe for Raj. Raj, what are your suggestions for best managing pain associated with pressure wounds and ulcers?
Again, with like pressure wound or ulcers, the key thing is about managing, treating the primary cause, which is treating the ulcer or treating the pressure wound itself into, whether if it's an infection, then making sure we have the right antibiotic, or if it is a vascular cause, are the things which can be done to fix it. Or again, if it's a non-healing ulcer, are we dealing with something like vasculitis? Kind of trying to work out what could be primary contributors leading to it, or is it just a pressure wound or following an injury or a trauma? So again, wound care. Coming back to pain itself, the key things again there is to see what aspects of the person's function is worsen. Is it pain only at the time of dressing change, or is it pain constant? Again, sometimes it could be burning type of pain. Is it more neuropathic pain around? So those are things which would kind of help me choose what type of drugs. If it is just around dressing change, can we use something very short acting, again, based on their liver and renal function, kind of choose what sort of, whether you go for an opioid or you go for an anti-inflammatory. You can use Penthrox these days, but again, in the elderly, the risks are something which we need to look at. And again, it's not through PBS, can help in short-term changes. There have been, like in the burns ward, the people are trying virtual reality as another way. I've not necessarily used it in dementia care or dressing change, but that may be something to kind of look at in the future. But largely, the pain treatment depends on what sort of interference it's causing, and for how long do we need the analgesic effect will definitely be helpful. If the wound is healed very well, sometimes you can use a bit of topical lignocaine too, but that's only if the wound is healed better. In that context, it does work better. I don't know if Gurveer has any other suggestions.
No, very, very well answered. In fact, I'm tuned in, and apologies, I had no information about the session happening. So yeah, I'm all tuned in now.
Right, that's my fault. So another question from Kaval: why is tramadol and Panadine not used much and frowned upon, but yet endone, Tarjan, Norseman, and fentanyl are freely used? Has it got anything to do with the drug companies?
I don't know about drug company, but could be social factors. I mean, the reason I say is that I did my initial training in New Zealand, and in New Zealand we never had any OxyContin issues because endone is not there in the market. Mundi Pharma is not there, so there's no Norspan, there's no endone, there's no OxyContin, and there they use codeine is what's largely used, morphine. So it again depends on what's the culture of the land, and then the second thing is what's your training and what you were using when you were doing, or what your other mentors were. There are definitely reasons why tramadol and codeine have kind of slowly gone away out of fashion, mainly because of harm minimization. It's not that both Nordspan, in the overall dose, it's not which opioid we use, it's the total oral morphine equivalent dose, which makes the bigger difference, whether it's half a tablet of Endone or if you took a packet of Penadine. Then that's where the risks came, is a lot of people would take the whole packet of Penadine, and the risk was more from paracetamol itself, and or when people were trying to separate the codeine out, so it was more harm minimization. That's one part, and again, both tramadol and Penadine both are prodrugs, so there are genetic differences, polymorphisms on how everyone metabolize these drugs. Some could be fast metabolizers or slow metabolizers. So they have different effects. So that's where drugs like tapentadol, which is not a prodrug, has kind of been much more used. Again, possible, time will tell us. It's been there in the market. There's definitely a huge more marketing in that way. I'm not saying, I mean, that's something which we need to be aware of. I'm not, I mean, there's more education there. Overall, yes, there has been more benefit. They say it has less likability in the context when they're given it to people who use drugs compared to Endone, or if they give them Endone or tapentadol, people choose Endone. But saying that, I have seen a few patients who do misuse, or kind of, when you say misuse, they take much more tapentadol than what you're prescribed, where people have been using 1,000 milligrams or higher of tapentadol. So again, it's not that it's misuse free, but there are a few things. It's not a prodrug, so it's an active metabolite. Doesn't need liver metabolisms or cytochrome mechanisms. Has an SNRI effect, which does have a little bit higher analgesic effect, and at least from the current literature, basic studies, the analgesic effect or the opioid effect is lower compared to another opioid. And so that's where tapentadol is becoming more popular. But saying that, again, it has its own risks, and again, assessing from person to person would still be very important.
Yeah, good one, Raj. And another interesting point might be the fact that the Endone and the short-acting medications. So using a short-acting medication like Endone and Panadine in a scenario where chronic pain is like a persistent problem, we would prefer something which is slow release. So a slow release Velexia or a slow release Tramadol is kind of preferred over a fast release medication. Having said that, some clinicians do like to have a slow release medication in the system and have a fast release for breakthrough pains or flare-up as well. So I do not think certain medications are frowned upon. I think it's about, people used to think that S4 medications like the Tramadol and the Panadine Forte are safer, which is not necessarily true. It's about the amount that it adds up to based on morphine equivalents on a daily basis. Yeah, so ultimately they're all opioids and they can all mess with our system, as we know.
And serotonin syndrome is another thing, particularly with tramadol. That's another reason where I think there has been almost no documented case with tapentadol as such, or there's very minimal serotonergic risks. So that's another reason why people move off. But again, when I speak to some of my older pain, some of my consult mentors, they're very happy using tramadol and they've not seen any case. Again, it just depends on familiarity and what is each person's personal experience. But dependence is definitely higher on, I mean, you see that at many opioids in general.
Okay, look, I think we're running way over time, so sorry about that, and thanks for sticking around. I think we're supposed to finish at 8, but anyway, I'd like to thank Raj for giving his excellent talk, and thank you all for coming. I think we also have another education session planned in a couple of days' time with Nicole, endocrinologist. So do let us know what specialists you'd like to hear from, what format you'd like. Would you like more talk, less talk, more questions, set things? How would you like it to run? We're kind of happy to be guided a little bit by you. I just want to thank you all for coming, and please have a look at our website and look at all the specialties that we have available. I do think of, if you are having issues with people with chronic pain, do think about referring to Raj. Do think about also if you think they'd benefit from procedures. Gabir does have an interventional practice with the Metro Pain Group, separate to Telecare, but that's a good it's a good option for people you think would benefit from some regional analgesia. So that might be an option. You might be able to refer to her through Telecare for an initial opinion. All right. If anyone has no further questions, we might wrap it up there, and we'll hopefully see you in a couple of days' time.
Thanks very much, everyone. Thank you.
Okay. Thank you for all of your time.
Thank you.
Enjoy the rest of the evening.
Thank you for watching. If you would like to submit a question, please feel free to email us at admin@telecareonline.com.au. Telecare, putting the care into telehealth.